are not relevant. So early recognition, intervention, how do you manage them? How do you prevent these allergies? And as well, educating these families or patients, and organizing a coordinated patient care. And how do you come to an accurate diagnosis and when to refer? Why are we talking about allergies? Allergy now is an increasing problem. It has, and over the last decades, we know that 30% of children internationally suffer from allergic disease. Allergic rhinitis is increasing by 20 to 30%, eczema and urticaria by 15 to 20%, as well as asthma and allergic disease. What we do know from the recent data is 1 in 3 adults, they do present with allergic problems, and allergy has increased, so the presentation of children has increased by 160%. That's how so there's different manifestations of allergy. They can present to you with urticaria, a rash all over the body, so an allergic reaction, urticaria, erythema, swelling of the soft tissue, intense itching, and with the child comes a very anxious parent, or eczema, so eczema in babies, a distressed child with inflamed skin, weepy, possibly infected eczema. So eczema can present either in, as you know, in small children or older children and in adults. So eczema can be type 1 or type 4 hypersensitivity reaction. Another presentation is allergic rhinitis, where it's nasal congestion, itchiness, sneezing, and runny nose. So having this constant cold, which can as well present with headaches, worsening of the asthma symptoms, and as well affecting the quality of life. Asthma as well is another presentation. So asthma has many reasons, but one of them is allergic reactions. So causing bronchial muscle constrictions, increased mucus secretion leading to cough and wheezing and difficulty in breathing. So the aim of today's talk, I expected that to be like an hour talk. I'll now with this technical problem, I'll try to, I think the time is limited. So I'll try and talk about the overview of allergy and the presentation, the basic sciences of allergic disease, assessment and diagnosis. If we've got time, then we'll talk about anaphylaxis and management. What is an allergy? Allergy is an abnormal reaction of the immune system in response to an otherwise harmless substance. You'd remember from your early sciences, the Coombs classifications of hypersensitivity, type 1, type 2, type 3, and 4. I've just learned from Instagram just lately the acronym of ABCD. So type 1 is a fast IgE-mediated. It's fast, it's due to histamine release. The presentations is allergy, anaphylaxis, asthma, allergic rhinitis. Type 2, which is the B, which is components, so antibody-related hemolytic anemia and rhesus disease. Type 3 is a component, so complex deposits in tissues, complement activation, so SLE, serum sickness, etc. And type 4, which is a delayed reaction, so you've got T cell mediated reaction, contact dermatitis, eczema can present in type 4. So allergy is a type 1 IgE-mediated reaction due to histamine release. This is a simple slide to tell you about the the complexity of the mechanism of allergy and what happens. So in a simpler way, an allergen is taken up by an antigen presenting cell. What happens is antigen processing, which turns the naive CD4 T cells and activates it to become a Th2 cell. So rather than going to Th1 pathway for the viruses, infections, and so on, activates the Th2 cells to produce leukotrienes, IL-4, IL-13. And that changes the B cells to, they generate specific IgEs, so specific IgEs that go and sit on the mast cells or basophil cells. And when further exposures to the allergens, what happens is degranulation. So that gives you a cascade of histamine release, cytokines, and immune mediators. What are these important for? I mean, it's important because it's a mechanism of allergy, but if you can remember or just keep in your mind, what is, when we're testing specific IgEs, that's what we're testing when we manage. We manage with antihistamines that block the histamine release from these mast cells and the basophils. Adrenaline as well works as an immune modulator for the whole cascade. And we've got now biological treatments, IL-4, IL-13, that is used in eczema management, asthma management, and so on. I'll go through this slide very quickly. But there are so many mediators here that are produced. So tryptase, histamine, heparin, your IL-4 and IL-13, and leukotrienes and platelet activating factor. And those all cause an inflammatory reaction leading to the allergic cascade. Why are we talking, why is allergy increasing? So we don't know, but there are so many series now. The hygiene hypothesis, we're more cleaner, use of detergents, our food is cleaner, our environment is much cleaner. We do know that children who are born, second born or third born in a family, they have more exposure to viruses and illnesses compared to the first child, and children born as well in farms and so on have lower risk of having allergic illnesses compared to others. Also, the use of antibiotics during pregnancy, during labor, and later on in as a child grows up, that's an increased risk of allergy and asthma. Acetaminophen, sorry, can't talk when I'm stressed. Obesity and asthma is another, obesity as well, that increases the risk of allergies. And vitamin D deficiency has been postulated to cause allergies or increase these allergies. If there's any questions, let me know. Allergy is a multi-systemic disease. It can affect many symptoms. Dizziness and weakness. I haven't seen seizures or syncope. It can cause eye problems, so itchy eyes, conjunctival injections, and increased lacrimation. The nose, it causes itchiness, congestion, sneezes, and clear rhinorrhea. Upper airway with hoarseness, stridor, laryngeal edema, cough, and in some cases complete obstruction. Cardiovascular with tachycardia, hypertension, arrhythmias, and cardiac arrest can affect the lower airway. Skin by erythema, flushing, the urticaria, and angioedema, which is swelling of the soft tissues. The GIT symptoms, where it presents with nausea, vomiting, cramping, abdominal pain, and diarrhea. And at times the diarrhea can be bloody diarrhea. So it is a multisystemic disease. Do you refer the child to multiple specialities, or is it one general pediatric practitioner that can manage this and then involve the allergist when needed. So yeah, it sometimes it's simple, you can manage, and there are other times that you need to involve other specialities. Another concept that I want to highlight to you is the allergic march or the atopic march. And this is about the presentation of allergic disease according to the age. So we know that babies, they present with GIT symptoms, so food allergies early on. And then, so they're dependent on milk, their food is introduced. So food allergies do present early on. And then eczema, so that presents after birth, say a few weeks after birth until they grow older. And then asthma, and then rhinitis. So between the age of 3 to 7, a child may have all these 4 problems. So they can have the food allergies, they can have the eczema, they can have the asthma and rhinitis, causing significant morbidity and affecting their quality of life. And again, we've got a few children as well, where we've got children that as they grow older, they also will have all these symptoms. So just bear this in mind when you're taking a history and managing a child with allergy. The causes of allergy are many. So inhaled allergens, you've got the house dust mite, the pollen, the grass and tree pollen, the molds, animal dander. Then you can ingest it, either medication or food allergies, or they can have injected by wasp and bee stings, or contact. So latex can be contact animal scratches and some plants. There are common food allergies that we inquire about in the history, and they can be obviously presenting food allergies. So milk and soya, peanuts and tree nuts, eggs, wheat, fish. And there's other increasing allergies nowadays. So we've got sesame, we've got kiwi. I mean, people can be allergic to many things, especially with the diversity of the diet that we're now exposed to. All the foods are present in supermarkets. So things that are, I mean, they're international. We're now exposed to it here in UK. But these are the common foods that we ask about in an allergy clinic. So what is food for some may be fierce poisons to others. I'm able to tolerate egg and milk and wheat, but others that can cause significant issues and anaphylaxis and some. Right, so we talked about what is an allergen, which is in a food allergy, it's an immune response to a food. And it's classified into IgE-mediated reaction and a non-IgE-mediated reaction. Sorry, jumping from one thing to another, food allergies is international, and where are we in the world can mean increased incidence of a type of allergy. Example, in USA and UK, milk and egg is most common, as well as peanut and tree nuts, and as well seafood. In France, as well as milk and egg and peanuts, there's also mustard. In Italy, more to that is seafood. In Israel and Middle East, sesame add on to milk and egg. Singapore, bird's nest, seafood, egg and milk. In Australia, again, milk, egg, peanuts and sesame. So 90% of food allergies is accounted for by the food allergies. Milk protein is the most common food antigen in infants and most common protein used in infant formulas. And I'm sure in this the program that Wala is putting with other fellow allergy doctors, will be talking about, you'll be taught about milk and egg and nut allergies and so on. Right. So the clinical history, once you've got this person, the child that presents, a clinical history is most important to take, and you must really take a very good clinical history to be able to enable you to diagnose what the issue is. The main purpose of your consultation is to decide, is it an allergy? Because if it's just a rash, rashes can be due to many things, viruses, infections, immune problems, and so on. So is it an allergy? And then next, is it IgE or is it non-IgE? And is it severe? How severe it is? So that's the main purpose of the history taking. We've got a few formats of history. So the eater's history, you need to take key elements in the history. Number one, exposure, the allergen, timing, the environment, how reproducible it is, and the symptoms. So if we take it in a context of a 2-year-old child who had an allergic reaction to food. So you ask about the exposure, what food was consumed. In this case, had egg. So the allergen now is the egg. Was it raw or was it cooked? So was it a scrambled egg or was it a cake? So cake is a very well cooked. The egg protein there is very well cooked. Or if it's an omelette or meranges or so, this would be a slightly cooked type of egg. So the allergen, timing, what happened, where, is it after 5 minutes, half an hour, or within an hour of eating the food, and what happened? So if it's within an hour or even 2 hours, that is related to this allergen. But if it happens like next day, it's not an IgE-mediated ones. The environment where the food allergic reactions happened. So was it at home? So the problem happened at home while feeding the child. And when did they have any previous problems with this? So when you ask about this, the mother will tell you that yes, it happened before when she was fed these types of food that contain eggs. And the symptoms of allergy, then the symptoms are typically multi-organ. So usually it's either urticaria, so nettle rash on the body. There will be lip swelling, there may be abdominal pain, there may be vomiting, as well as diarrhea. In some severe cases, as anaphylaxis, it does affect the airway and the circulation. So the eater's history, I remember that, the exposure, the allergen, the timing, the environment, how reproducible the symptoms are, and what are the symptoms. When we ask, again, we've got these questionnaires that I told you about, then we ask about the personal history. Does the child have any of the atopic march thing that we talked about? So is there asthma? Is there eczema? Is there rhinitis? Is there a family history of atopic disease? What about the parents and the siblings? And what is the food that is avoided and why? So some parents will tell you that I've given her egg before, but she just spits it out and she doesn't eat it. So they haven't thought about this as an allergy. Or we've avoided the cake because she doesn't like it. The food in contact to the mouth will cause itchiness and there will be an aversion. Some families avoid foods because their lifestyle. So we've got vegan families that they don't eat milk or and foods are avoided. So it's important to be aware of food, why is food avoided, and what food is avoided and why, and who suspects the allergen. That's important. The feeding history. You need to ask about these common food allergies that we talked about. Are they drinking milk? Are they eating egg? What about nuts? Are they eating fish and sesame and so on? And then you list your symptoms, and then response to treatments of eliminations and reintroduction. So when it's being given again, what happened? So this is the allergy-focused history proforma that we have, or it's nationally used. So the personal history of allergic problems, the family history, the age of onset in relation to the change of diet, and you ask about all these foods, and you give details. And what are the symptoms? So skin, GIT, respiratory, cardiovascular, and what time course between the exposure onset of symptoms and what quantities food is needed to trigger a reaction. Have they eaten the whole omelette? Have they eaten the whole cake? Have they eaten the whole nut? And they were able to tolerate it, but in higher amounts they couldn't. So that's important to determine, again, the tolerance. We talked about the family history, we ask about the parents or sibling. One parent or sibling increase the risk to 20 to 40%, and if both parents, the risk of allergic reactions increase to 40 to 60%. So again, when we're talking taking the history, is it IgE mediated versus non-IgE mediated? In IgE mediated, there's quick onset, anaphylaxis in severe case. We've got a well-defined mechanism, which is which is the histamine release and so on. It's easy to diagnose, and we've got validated tests. In the non-IgE, they are of delayed onset. So things happen next day or in 24 hours or 48 hours. They can be eczema, reflux. The mechanism here is unclear. It's harder to diagnose, and there is no validated test. So the validated tests in IgE are either blood testing, IgE testing, or skin prick testing, but in an non-IgE, there's no test for that. So the parents that come to you with a hair test, or so the hair tests, they go to one of these corner shops or Chinese shops, and then they give them a list of whole allergens. That is not a validated test. Or kinesiology, where they go to someone that puts a piece of cheese on the arm, and then the muscle tone decreases. That's not a validated test. IgG testing that you can find online is not a validated test. But your history here is important to decipher between, is it IgE or non-IgE mediated? That's here just a list of symptoms. I'll share the slides later. So if you wanted. So it gives you a list between the IgE-mediated symptoms and a non-IgE-mediated symptoms. That's a GIT in the skin, pruritus, erythema, urticaria. Non-IgE, that's again confusing, but atopic eczema can be non-IgE-mediated. Respiratory symptoms, nasal itching, sneezing, rhinorrhea, congestion, that's usually IgE. And then you've got a mixture between IgE and non-IgE and the lower respiratory tract. Okay. Non-IgE reactions, I'm just going to name them. This is a topic for for one of the other sessions. So GIT, eosinophilic gastroenteropathy, food protein proctocolitis, food protein induced enteropathy, food protein-induced enterocolitis. They all are non-IgE-mediated reactions. In here, blood tests are not valid. The specific IgE will be low, but it does not mean that the person or the child does not have these issues. They present with abdominal pain, vomiting, diarrhea, loss of weight. In food protein-induced enterocolitis, that can present with sepsis-like symptoms, and it is the anaphylaxis in a non-IgE-mediated reaction. So celiac disease is, as you know, it's an IgE-mediated one rather than IgE. Others, eczema, reflux, colic, and constipation. I'm not sure about constipation, but I know it's coated, and it's due to a non-IgE-mediated reaction. You see a lot of, well, a few families that come and say, the child is constipated, I've taken the milk out of the diet to manage the constipation. Personally, I'm not sure about this. Okay. So when to refer? Usually these presentations are managed by, would like it to be managed at GP land, but to refer if there are acute systemic reactions or severe delayed reactions or faltering growth and GIT symptoms, significant atopic eczema with suspicion of multiple food allergies and possible multiple food allergies. Just a note in this atopic eczema, please do not initiate specific IgEs in significant eczema because they will have false positive results. Why is it important to diagnose food allergy appropriately? Because it takes 39% longer to shop. It comes at a greater expense. The quality of life scores is worse than type 1 diabetes. Anxiety after diagnosis is greater than cancer. It is, believe me, these parents are so anxious that their child will have anaphylaxis. There is risk of compromised nutrition because if the milk is taken out, what is else in the diet? What have they put in the diet instead? If these nuts or egg or fish and so on, this will compromise the nutrition if they're taken out inappropriately. And obviously there is a risk of a fatal reaction if the allergen is not known. So hence the importance of having a diagnosis, an appropriate diagnosis of food allergy. In these children as well, review their asthma because this is a high risk for anaphylaxis. So we need to be aware of what is the triggering of the symptoms, and as well manage the comorbidities of the rhinitis, GIT symptoms, and eczema. Okay, are we okay, Voila?
Yes.
Okay.
Very good. Yeah.
Right.
Yeah.
So next I'll go to the allergy testing. There are two types of tests: skin prick testing and specific IgE testing. What's important is line fishing and not trawling. So from your history, you know now what you had an idea of what causes the allergy. So go and fish for this rather than you spit the net out and then come up with things that you don't know. There may be things that the person is able to tolerate, but they come with non-specific numbers. So what do you do about them? Will you go and say, no, you take it out of the diet? So make sure that you are line fishing. Okay. It's important in the allergy testing to be aware that it's either the skin prick testing or specific IgE predicts the likelihood of allergy. It does not predict the severity of a reaction, but a negative test is strongly predictive. So if we've got a high specific skin prick test of, example, 10 times 10 millimeter, it doesn't tell me that this child will have anaphylaxis. It just tells me that, no, he's sensitive. Or a specific IgE of, example, 14, just tells me that this child is sensitive, but it does not predict the severity of the reaction. With regards to the IgE, they are now readily available. You test only if you suspect what you suspect is causing the problem. So it tells you if the individual is synthesized, and the results usually, it's negative if it's less than 0.35. If we have like a child that has, or an adult that has allergic rhinitis symptoms, from your history, you know that this person has symptoms usually in between May to September. The most common pollen is usually the grass pollen. So you'll then go and ask about, it's easy now, the aeroallergens are grouped together. You can either ask about grass specific IgE or tree as well as tree IgE. But you wouldn't go and ask for specific IgEs to food there. You'll put in your peanut and your egg and so on. This is not relevant. So the specific IgEs on WebEyes, they come as, I don't think, they used to be apparent for us. So so we used to be able to put aeroallergens. I think now this has been hidden on WebEyes. So we ask about aeroallergens. So how's the smite, your grass, your trees, the pollen and molds, and fairy animals. Or if you want to be specific, and this family does not have any animals, then you don't need to be putting the cats and dogs and horses and so on. Is that clear? Yeah. Okay. Yes. With regards to food, you need to be specific about what foods. So if they're able to tolerate nuts, you don't go and look for specific IgEs for nuts or tree nuts. If it's only for egg, you only do the egg. So if we've got this child that came presenting that I told you about with the egg allergy, they presented to the GP. The GP, from the eater's history, diagnosed that this child has a reaction to cooked or raw egg because she was eating an omelette. The specific IgE came, they requested egg white. So the specific IgE came as 14. That means that this child is allergic to this egg protein. And then you take it from there. Is the child is able to tolerate egg in a cooked form, in form of eggs, so sorry, in form of cake, so hence continue on the very well cooked egg, which is your cakes, your biscuits and so on, and then move on to an egg ladder. All these guidelines are available on the Basaki. What I'm saying is just giving you a flavor of what the specific IgE testing is. You need to be specific. One size does not suit all, so you may have a one here or a two. A common thing is when a child is referred to an allergy clinic with abdominal pain, and you'll find that your colleague has requested the food panel, which includes eggs, milk, nuts, and all the foods, and sesame. Then comes the milk as one or two, but the child has been able to drink milk and so on. So what they do prior to coming to clinic is advise them, stop the milk until you go and see an allergist for a skin prick testing. The child was able to tolerate milk. Why did you take it out of the diet? And this is what I mean by one size does not suit all, because this one may be, another child may be presenting with an allergic symptom then. So it's all in the history. Right, the skin prick testing, So what we do is we have solutions, and then what we do the specific solutions on the skin, and then we prick each allergen, and in about 15 minutes we'll have a wheel. We'll then measure the wheel diameter. So usually if it's less than 3 millimeter, it's negative, and then if it's 5 or 10 by 5 or 15, that tells you about how allergic, no, not how allergic, but is a person allergic or not. The problem is that it needs skill, so it needs competency to choose and perform and interpret. It does not mean that GPs can't do it. We've got a few GPs around the country that do that. It just needs time. But by the time you've had done your clinical history, and then arrange the skin prick testing, and then ask them to wait outside for about 15 minutes for the test to cook, and then you came back to tell them about what they are allergic to. That takes time, but it is within 15 minutes, you're able to tell them that it's straight away, and it for families, they find that very informative, rather than having a blood sample sent to the lab and you'll get the results in about 7 days or 10 days. So what is it important is to stop the antihistamine at least 48 hours to 72 hours, make sure that there's no eczema at the skin prick testing site, and topical steroids can affect the results. So once you've got either your specific IgE or your skin prick testing, a positive result and a positive history confirm the relevance of a specific trigger to the patient. A positive result on its own is meaningless, because 80% of people who are synthesized will not get symptoms and exposure, and a negative test is very predictive. Okay, following this, once you've identified what the allergen is, you avoid the allergen, and you plan for accidental exposures. Although I said here strict avoidance of allergens, we have got milk ladders, which we use in non-IgE-mediated milk allergy, and we've got egg ladders that we use cautiously in egg allergies. There are desensitization centres privately in UK who desensitize the children against nuts and sesame and so on, but it needs to be done very carefully because of the risk of anaphylaxis. Okay, are we okay for time?
Yes, I think everybody is happy to stay if you are okay with the time.
Okay, any questions so far about?
Yeah.
Okay, is there any questions so far? I can't see anybody.
No.
Can I ask a question?
Yeah.
In terms of whether you choose skin prick testing or IgE, is one recommended above the other?
No. So the skin prick testing, it needs competency. So you need somebody that is trained to do that, but this training is you can acquire it very quickly. So when you do it, how you do it, and reading the test, so that needs training. But it is easy, it's quick, it is not expensive, because so the vial of the bottle of the allergen costs about £15, and you're only taking a drop. So money-wise, this is less expensive compared to the specific IgE that will go to the lab and come back in about 7 to 10 days. So this is the only reason. But they're both similar. Did that answer your question?
Yeah. So if you're in, say you're in a GP surgery, you've seen a child and you think that they have a food allergy, we're more likely to request IgEs.
Yeah.
Otherwise, we'd have to refer them to the hospital for skin prick testing.
And absolutely. And if you're confident enough to be able to recognize the allergen and only do the specific IgE for that allergen, and when the result comes back to you, you're aware of what that means, and then tell them what to do about avoiding or managing and so on, by all means, yes. Right, so this is about food allergies. What about allergic rhinitis and asthma? Simply, you take a specific IgE for aeroallergens, and then the results come back to you as this person is sensitive to these either tree or grass. Then you inform them about how to avoid or manage the allergen load. If it's house dust mite, managing the allergen load of the house dust mite. There's leaflets available on Allergy UK website, and as well giving them an antihistamine regularly if they're grass and trees for the grass and tree season, which is from March on to September, using them prophylactically for house dust mites all year round, and as well managing their allergic rhinitis. So yes, in GP land, you can use specific IgEs. And if in doubt, you can refer. Is that okay?
Yeah, thank you.
Okay, right. So moving on. If I summarize my previous slides, it's what is allergy? What is the basic science about allergy? How to take an allergic focused history, and as well the use of specific IgE and skin prick testing. We haven't talked about the avoidance measures and so on. I think that will come in other things. But I think it's important to be talking about anaphylaxis, because this is the severe presentation of allergies. 20 deaths per year do happen, and 1 in 1,333 of the population in England have experienced anaphylaxis. So it is rare, but it happens, and we have had a few children who have died, like the likes of Benedict, who was 5 years old, milk allergic. Instead of oat milk, his normal oat milk, he was given milk at school, and he died. We've got what's her name? Yeah, so there is, what's her name? Sorry, I forgot her name. But her family have done a whole foundation program for training of allergy. So she died following eating the Pret sandwich that had sesame, and she had multiple allergies. And you've heard about other stories of teenagers that died from food exposure. Right, so anaphylaxis, it's a severe life-threatening reaction. It involves the airway, pharyngeal and laryngeal edema, breathing, bronchospasm, and tachypnea, and circulation. And in most cases, associated with skin and mucosal changes. We've got the Resuscitation Council management of acute anaphylaxis that do go and see, and I'm sure you're aware about it. Airway, breathing, circulation, and disability, but the early treatment is adrenaline, adrenaline, adrenaline. First you do the adrenaline, and then you call for help. So what does adrenaline do? It acts on the alpha receptors, constricting the blood vessels that are vasodilated from the allergic cascade, and as well works on the beta receptors to relax the airway that have gone into bronchospasm due to the allergic cascade. It works within 2 to 5 minutes, and it lasts about 20 to 30 minutes. So in anaphylaxis, prompt treatment with adrenaline is critical. Adrenaline is the first line of treatment and the only medication proven to stop a potentially life-threatening allergic reaction. Patients and caregivers wait about 9 minutes to dose up the adrenaline. And I've been in this situation. You think that you've got a child that is wheezy. So I'm a person that every week I've got an allergy clinic, and we train these parents about how to use the auto-injectors. We had I'm saying this because I shouldn't be putting up my negatives up there, but it's something that I focus on now more. So we had a child that came in with for a walnut challenge. After his first bite, he became withdrawn, had abdominal pain, and we thought it's a moderate reaction. He had a few urticarial spots. And about using the adrenaline. We didn't and too long. He started wheezing, he started coughing. So the thought that came to my mind are, am I overdoing it? Am I going to make this caretaker anxious? But adrenaline had to be given. So early adrenaline use is associated with reduced risk of receiving multiple adrenaline doses. And I'm quoting this story because so I'm a person that deals with allergy day in, day out, need to think adrenaline, and then, and if in doubt, use adrenaline. So adrenaline. Early adrenaline associated with reduced risk of receiving multiple adrenaline doses. And a patient treated with early adrenaline is less likely to be hospitalized. From research data, we know delaying treatment by more than 30 minutes from onset of symptoms is associated with biphasic causes. And in all the patients, the majority of patients who died, there has been delay in administering the adrenaline. Okay, the adrenaline dose according to age, more than 12 years old, 500 microgram, you take it by syringe, so 0.5 mils, or 300 microgram, 0.3 mils, if small or prepubertal. 6 to 12 years old, 300 microgram, or not to 6 years old, 150 microgram. Then, yes, you need to refer these children to secondary care and make sure that you provide an appropriate adrenaline injector. And you also train the people, the children, the family. What we find now is that they are prescribed an adrenaline pen, but the families are not told how to use it. So it's important to take time to show them when and how to use it and optimize the asthma management, because unmanaged asthma may risk death. And do they have an emergency plan? Right. So who, what, and when? So I'll be telling you about what types of pen. Does it go and repeat? Yes, it does go and repeat. And there needs to be a review system in place. In the hospital, we see them once. And I possibly see them again. Some clinics only see them once and then discharge the GP, but the GPs need to have a review system in place. Okay, so there are 3 types of adrenaline. There's 2 types of pen, and the new kid on board now is the Uronephi, which is an intranasal one that has just been launched. So EpiPen, it costs £26. There's the 0.3 milligram, and there's a junior 0.15 milligram. So the junior up to the weight of 30 kilos, and the adult one from the weight of 30 kilos onwards. The shelf life is about 18 months. There's Jext, again 0.3 and 0.15 milligram, shelf life of 18 months. The Uronephi is a 2 milligram one. It's intranasal, and what is hoped is that the hesitancy of giving the pen either by the patient or the parents, because it is a pen, it's an injection, may decrease because there is an intranasal type now. So this is an EpiPen. It's got blue cap here and the orange here. The syringe is shielded. There is a small window here to show you if it's clear, it's in date, and it also tells you about the expiry date. So is it clear, is it turbid? And then the Jext. So there's a junior Jext and there's 0.3 milligram Jext. Right, and this is the urinephy, which is a new one. It's, I think some areas are talking to the ICBs about getting them on the formulary. So it is easy. You use it in the nose, a squirt, and that's it. And if it's needed to be repeated, it can be repeated in the same nostril in about 5 minutes. Just back to the Jext and the EpiPen. If it is to be repeated in 5 minutes, you do the the other side, so not the same side, because there already will be vasoconstriction. In the Nephi one, urinephy one, it's in the same nostril. Currently, it's indicated for adults and children with a weight of 30 kilogram. Again, one of the common questions by the GP, why, Dr. Fawi, are you saying 2 at all times? It is expensive. It costs £26. Yes, it costs £26, but they need to, the MHRA tell us that they need to carry 2 at all times. Because the biphasic reaction may be again in 5 minutes, or you may have fired it wrong, or you fired it, fired it wrong, and instead of, as you're holding it as a pen, the needle has gone through your thumb. It's easily done, and it happens in experience by 2 experienced health professionals in A&E, or it's faulty. So it's important to carry 2 at all times. Age and adrenaline. So at the age, we'll say 8 years old, because we don't usually weigh the children after, I mean, we weigh them when they come to clinic. But if you're just having the notes there, I think at the age of 8 years old, change to the adult auto-injector. Right, the British Society of Allergy has allergy action plans for EpiPen, for Jext. There used to be Emerade, but that stopped. And I think they're looking at developing the urinephy guidelines. There's also a generic plan for individual assessed not needing auto-injector, and that tells them about, what it tells about is the difference between a mild to moderate reactions, having swollen lips, face and eyes, itchy tingling mouth, hives, and itchy skin rash, abdominal pain or vomiting, sudden change of behavior. These are all mild to moderate. Even if the face is all swollen, the eyes swollen, the lips swelling, the rash is all over the body. Mild to moderate reaction, what you do, you give an antihistamine. We tell them about the histamine dose. So usually we'll do cetirizine, not Piriton, because chlorpheniramine will cause sedation. And then you'll think about this child is now dizzy and sleepy and unconscious, and you worry about this. So giving an antihistamine, cetirizine, the cetirizine usually works between 20 to 25 minutes, similar to the chlorpheniramine. And then watch out for signs of anaphylaxis. So persistent cough, so airway, persistent cough, hoarse voice, difficulty swallowing, swollen tongue, breathing difficulty or noisy breathing, wheezing, persistent cough, and consciousness, dizziness, floppy, and so on. So if any of these, you lay the child flat, make sure it's flat, the child is flat, or sitting down, but don't battle with a child that just wants to stand up and so on. So lie the child flat, or allowed to sit, and dial 999 and say anaphylaxis. So this is an auto-injector plan without, it's an allergy action plan without an auto-injector. When you've said anaphylaxis, the triage for the ambulance system will prioritize you compared to any other. So you won't be waiting for another 6 hours for the ambulance to come. So there are allergy actions plans for EpiPen for Jext, and as I said, there will be an Epi, and in the Jext and the EpiPen, they will tell you to lay the person flat or sit down, to give the EpiPen and to give the first dose, and then you call for the ambulance. Right, so the management principles in allergies, allergen avoidance, once you identified what the allergen is, so for aeroallergens, you give them leaflets about how to manage the allergen load. You cannot live in a bubble. So decreasing the allergen load. For grass and trees, you give antihistamines in the season. For house dust mites, it's all year round. And as well, decreasing the allergen load as much as possible. If it's food, then dietetic education and follow-up. And if there are multiple foods, we refer to a dietitian to talk about what labels of food to look into and what are the other alternatives to be used. Recognizing the reactions, so education and follow-up, giving the antihistamines and EpiPen. And remember, the antihistamines are not used in a severe allergic reaction. You give the antihistamine only in a mild to moderate reaction. And then if they have asthma, ensure that the asthma is very well controlled. Yeah, because this is a risk of, it increases the risk of death. Very quickly, I mean, the slides will be with you. So when you prescribe an auto-injector, there's absolute indications and relative indications. So a previous cardiovascular respiratory reaction to a food or insect sting or latex, you give an auto-injector. Food allergy and coexistent asthma, exercise-induced anaphylaxis, remoteness of home from medical facilities, and idiopathic anaphylaxis. Relative indications may be reactions to small amount of food, airborne food, or contact via skin. History of a previous mild reaction to peanut or tree nut. That's the most common ones that we see here. Remoteness for home or of home, and allergic reaction to food as a teenagers. Teenagers are risk-taking, so yeah, it's important to see them and talk about the management, allergy management, and anaphylaxis management. Make sure that they have 2 EpiPens because 35% of patients may require more than 1 adrenaline dose, and as many as 20% of patients will go on to develop a biphasic reaction that may be many hours later. And remember to change the auto-injector if the child becomes 25 kilos. So the window between 25 to 30 kilograms. Yeah, so I raced through this. I talked to you about the overview of allergy and mechanism, the common manifestations of allergic disease, how to assess and diagnose the auto-injectors, and indication to prescribe and how to use. Yeah, and there's a few references here. Any questions? I'm going to stop sharing if that's okay, so I can see you.
Thank you. Thank you very much, Dr. Fawi. Very interesting presentation and well presented, well prepared. Thank you.
Okay. Any questions?
I think, can you just clarify, I think there's a difference in the way you administer the 2 different types of pen,
yeah.
Is that right?
There is. Subtle difference, but there is. So in the EpiPen, what you do, you 10 centimeter away, and you just stab. So the blue to the sky and the orange to the side. And what you do is 2/3 of the side down, away from the seam of the trousers, and you stab. And you count 1,000, 2,000, 3,000, or 1 elephant, 2 elephants, 3 elephants. You do not need to rub. With the Jext, you stab it. And yeah, again, 1,000, 2,000, and 3,000. Actually, for the Jext, you count until 10. Yeah, so this is a difference, but 2/3 of the side down, and laterally away from the seam of the trousers. You do not need to take the trousers down. Is that clear? And then with the Neffy, it's new. So it's like it's a nasal device. And what you do is, sorry, haven't got the device with me, but you hold it straight up the nose. You don't test it, because when you test it, the dose has gone. And you put it up the nostril until the fingers touch the nose and hold straight. And then you press the plunger firmly. Do not angle to the septum or to the side of the nose and seek medical treatment. So we hope that when this is easily prescribable, that the people will be using it more.
Okay, thank you.
There are so we give the patients allergy action plans, and we also tell them to go to the website of the company, the EpiPen and the Jex, and also there's YouTube videos about it.
Okay, thanks.
Okay.
Thank you all who attended today. Please remember to complete the feedback. I put it on the chat.
Brilliant. Thank you very much for listening. And we're sorry for the blitz or bitch or what a blitz. Sorry, English is not my first language. So yeah, but thank you very much for sorting this out.
Thank you very much. Thank you for your
Okay.
time.
Okay, take care then. Bye.
All. Bye.
Bye. Bye all. Have a good day.
Thanks, you too. Bye.
Bye.
Thank you.
Bye.